Okay, guys. So I thought I might speak a little bit about the ventilation. So we have minute ventilation over here and alveolar ventilation. So what is minute ventilation? So minute ventilation is essentially abbreviated as VE. Now, why is it abbreviated as VE? Well, the reason that we do this is because it's a volume exhale. Now, remember when minute ventilation essentially means a normal breath. I'm really literally right now I'm minute ventilating. But what does that mean? Because you're the fact that you inhale and you exhale, both of them are the same. The amount that you're inhaling is the amount you're exhaling. So that's why we just use exhalation. Because if we know exhalation, we probably know what is going to be inhalation. So that's going to be the key over here. So I told you volume of gas entering and exiting the lungs per minute. So the minute ventilation of volume of exhalation is going to equal to tidal volume. Tidal volume is kind of like how much you're breathing at a specific moment of time times the respiratory rate. So how many times you respire during a minute. And the normal values of respiratory rate is usually 12 to 20 breaths per minute. And the tidal volume is going to be essentially around 500 milliliters per breath. Dead space is 150 milliliters per breath. And yeah, so now coming to alveolar. So this is going to be VA, volume alveolar. And this is the total volume of gas that reaches the alveoli each minute. So there's going to be volume of alveolar. So that's going to be your tidal volume minus your essentially your dead space. Because we want to know the reason that we're going to be reducing our dead space over here is because essentially this is the volume that is essentially not involved in gas exchange. So if you have an alveoli over here, this is the gas which is involved in gas exchange, but this above over here is your dead space. We're not really using that. And you time minus the two, and you get the one that's reaching the alveoli, and you times the respiratory rate. Chest wall and properties, we can see lung inflammation has a different pressure volume curve than lung deflation due to the need to overcome surface tension during inflammation. So as we know in surface tension, when we have surface tension, the more we have surface tension, the more likely we are to collapse. And surfactant decreases surface tension, as we covered. And hysteresis is basically the difference in pressure between inhalation, so the amount that we inhale, and the pressure exhaling. It's the difference between the two. And because the historical reasons that there are small pressures or pulmonary pressures, they are going to be presented as C as centimeter H2O. Now, many students here get confused with the pulmonary arterial pressure, but that's going to be stay the same. Artery pressure is always high. And this pressure over here, centimeters of water, is really important as it's basically how much you're breathing, and that's going to be, it's not going to be as high as the artery system, which is quite high. Let's come into the graphs over here. So lung volume change, and this is going to be we're very simple over here. We inhale, exhale. Okay. Let's come to alveolar pressure. So alveolar pressure, you kind of have to go negative because you're kind of creating that suction, that draw for air, and then you go positive. You're bringing out, allowing that to go positive. And interpleural pressure, again, you're going a bit negative, and then you go on and you go positive. And the reason interpleural pressure is always negative, and that's because we're always having that suction. Okay, elastic recoil is basically the tendency for the lungs to collapse and the chest to kind of go out. Okay, now imagine your chest, it's like really strong. Okay, and you're going to be expanding your chest, and the lungs are like really elastic, they have a lot of fibers. So I'm asking you watching this video, if your lungs has a lot of fiber, a lot of elasticity, is there more likely your lung is going to collapse or it's going to expand? So it has a lot of elasticity. It's more likely it's going to kind of collapse, kind of get small. So that's kind of the two balance. The lungs are always trying to become small, and the chest wall is trying to get big. And FRC stands for functional residual capacity. The airway, and that's essentially like functional residual capacity is a capacity at which we have only the expiratory reserve volume and the residual volume. So essentially, at this moment, you're not inhaling or you're not exhaling. So this is a proper equilibrium, and that's the airway, the airway pressure, like this airway, and the alveolar pressure are equal. Atmospheric pressure is going to equal to zero. Interpleural pressure is negative, preventing atelectasis. The inward pull of the lung are balanced by the outward pull of the chest wall. Systemic pressure is atmospheric, and pulmonary vascular resistance is at a minimum. Now, why is this going to be at a minimum? Well, this is a very interesting point. The reason that this is going to be at a minimum is that due to the fact that, right, so the reason that we're going to be having over here a lung volume is going to be quite low, and that's going to be due to the fact that basically when there is low lung volume, the extra alveolar vessels they collapse, and that will increase resistance. And a high lung volume, the alveolars expand. That would compress capillaries, and that again increases resistance. Okay. Now at functional residual capacity, there's a sweet spot, and the alveoli are moderately extended, and the extra alveolar vessels are open. So neither is compressed. So the pulmonary vascular resistance is going to be very low. So when you have low lung volumes, you can imagine the extra alveolar vessels, they're also collapsed, and there's increased resistance. But when you have high, there's pressure, increased resistance. Functional residual capacity, they are open, so they're not really compressed, and there's not much resistance, so the resistance is going to be the lowest over here. Yeah. Okay. So now coming back over here, that uh, we have over here change in volume. Okay, for change in pressure, so volume over pressure is inversely proportional to wall stiffness and increased by surfactant. We have increased compliance, so lungs easier to fill. For example, emphysema, older adults. So emphysema, as we know, we have a lot of smoking, or it can be alpha-1 antitrypsin deficiency, where we're getting destruction of the lung parenchyma. So it means less fibrosis, less elasticity. So your lungs are going to expand. And older adults, same thing. We kind of get wear and tear of the lungs. In decreased compliance is going to be due to the fact that we are going to be having pulmonary fibrosis, any fibrotic, any sort of like fluid state, pulmonary edema, pneumonia, and ARDS. Coming over here into this diagram, we can see that this is going to be the volume on the y-axis, and we can see the airway pressure on the x-axis. So as the volume is increasing, as we get a volume increase, and as we got an increase in pressure because we're having more air, we're essentially getting more expansion, and we can see that this emphysema is going to be expanding. But over here, it's not going to be expanding as much. It's going to be quite fibrotic, so it's going to be quite shut. So lung chest wall compliance and net compliance. Okay. Now I have questions over here. A patient with emphysema has lungs that are easier to fill. Increased compliance. Which of the following is likely true regarding compliance? So increased compliance is harder to fill? No. Decreased compliance occurs? No. Increased compliance, the lungs are easier to fill. So that's going to be correct answer. According to your text, which condition will lead to a decrease in lung compliance? Normal aging, no. Emphysema, no. And pneumonia is going to be the correct answer here. What is the definition of hysterexis as defined in the text? So it's going to be basically the pressure, inhalation, and exhalation. Okay, now we can see over here, calculate the minute ventilation. Minute ventilation, like I said, is going to be your tidal volume times respiratory rate. So our tidal volume is 500. 500 times 12 is going to be 6,000. So that's going to be your correct answer here. At functional review capacity, what is the following statement is true? So the airway pressure is negative, interpupillary pressure is positive. No, interpupillary pressure is always negative, so this is wrong. The inward pull of the lung is balanced by the outer pull of the chest wall. That is also incorrect. Airway is lower than atmospheric. That's incorrect. Sorry, the inward pull is balanced by the outward. That is correct. B is the correct answer. And these are all wrong over here. Alveolar ventilation is defined as total volume entry and exiting. No, that's tidal volume. Only volume of gas enters alveolar. That's completely correct answer. And yeah, so that's going to be over here. Okay, guys, just to give you guys a quick summary over here, that basically we need to know that minute ventilation is tidal volume times respiratory rate. Alveolar ventilation is tidal volume minus dead space times respiratory rate. Lung wall compliance, hysterexis is difference between inhalation and exhalation. We can see that the states where we are going to have more compliance, more expansion, emphysema, and normal aging, and less compliance is going to be fibrosis or pneumonia of ARDS from edema. Hopefully, you found this video useful. Thank you for watching.